So yeah, there's like a payment plan option once you sign up. But we reserved May 2nd, 3rd, and 4th, like I wanted. Okay?
Are you teaching it or just?
They will not let me teach it because that's considered a conflict of interest.
Okay. I was wondering.
I requested an instructor that is energetic, and I requested somebody for you guys. Yeah. No, she doesn't. She's actually limited in our office. Yeah. All right, gonna turn it over to Loren so she can get started with you guys. And y'all should all be able to see your grades on your CJN. Y'all got it?
Okay, can everybody hear me? Is this okay? I'm not too loud? Okay. If you will, that's your class ID. Get into your Lumio. Yes. And it's 636105. All right. Anybody not there yet? Okay. Everybody good? All right. Okay, and everybody got the PowerPoints about respiratory dysfunction and everything worked out good. All right. Okay, if y'all will, we're going to start with what are some signs and symptoms of respiratory dysfunction and distress in infants or children? And this should be, you should be able to put your answer in on here so we can discuss. All right, that's some good ones, especially the ones that are particular to infants, like the nasal flaring that we've got on there, the grunting, those retractions, whether they're substernal, intercostal, the different locations of the retractions. Restless and irritable, poor feeding, because they're tired. You know, they're working to eat, or they're working to breathe. Breathing comes before eating, so that feeding's going to definitely decrease. I've got just some little videos, because when you're assessing respiratory status of children, it's to me more difficult than an adult, because an adult, they can firstly describe how they feel. Are they short of breath? Do they feel a heaviness? They can also, it's easier to listen to them because they can follow directions most of the time and be quiet unless you auscultate. However, on a child, that's usually when they're going to be screaming, fidgeting, fighting. And then also the O2 sat probe, sometimes, especially as you've seen an impact, can take forever. So you're going to want to be able to pick up on these signs and symptoms, because they're often going to be much easier to pick up on than what you're normally used to doing. Now forgive me if this doesn't play. Let's see. Let's try again. Okay, Miss Rigby, how do we make this play out loud? Yeah. I thought I did it. Yeah, I thought I turned all the sound on. No. Okay, well, they have the sound on their computers, right? Okay, well, y'all can turn the sound up on your computer and play it.
Try it on your device. It won't, no sound. It won't play.
It'll play with no sound. Because it worked yesterday. Let's see if it's just this video.
She's gonna try another video.
Woo! Yeah. Okay, good deal. It was just that one. Okay. Anyways, this one, you can see, though, his retractions and the kind of seesaw respirations. And then this one is grunting, like we talked about. He's got some retractions going as well, a little bit of head bobbing. Okay, now this one is head bobbing like crazy. They're not always this pronounced, but. Because they're having so much trouble breathing, they're using all those extra muscles to help it move. See the nasal flaring. All right. We don't have to do that yet, but anyways, so signs and symptoms of respiratory distress in children, like we talked about, that nasal flaring, the grunting, the retractions. They're either going to be extremely irritable or lethargic. So we want to watch any changes in their baseline status, mental status. You're going to want to watch for, like we said, poor feeding. Most babies or all babies are programmed to breathe through their nose. So when that nose gets congested, there goes their main way to breathe, especially when you're trying to bottle feed or breastfeed. So you want to make sure that we're suctioning and paying attention to those airways as well. Respiratory sounds, we're looking for like wheezing, stridor, crackles, absence of breath sounds where there's no movement of the air. These are all things that we're going to be assessing for. So we will Move on to our first thing we talked about in PowerPoint after the basics, which was strep throat. What causes strep throat mainly? Which bacteria? Yep, group A beta hemolytic streptococcus is the main one. Now, how can we test for that? How do we know that's it? Swab, that's right. Now, some kids are carriers and they swab all the time, or they swab positive all the time. But for the most part, we rely on the swab. Now, if the swab is negative and they're showing all those signs and symptoms, what are some other symptoms that might show that it's a rash? That's right. That rash is going to be strep throat. And now a lot of times what I've seen in practice is the kids may have a sore throat or they may not be able to tell us that they have a sore throat, but they're going to have that rash. And it's like sandpaper, little bitty red bumps. And usually once they're swabbed, they're going to be positive for strep. So watch out for that rash as well. What are some interventions that we can do for our patient with tonsillitis? Mm-hmm. Right. Mm-hmm. What are we watching out for? What are we wanting to monitor? Intake, that's a good one. That airway, we want to make sure that the airway, there's not getting too swollen, and they can continue to move air. You also want to check to make sure that they're not spreading that infection anywhere. We talked about a lot of times in kids that respiratory tract in children is shorter, so it's much easier for them to start an infection here and spread down. And then we will move on to tonsillitis. Tonsillitis is also an infection of the throat, but it's more so of the tonsils. They get big and swollen. Sometimes they have the exudate, sometimes they don't. Like I said in the PowerPoint, it can either be where they have multiple tonsil infections before they get their tonsils removed, or it can be an emergent. Like when I went in with mine, it's the first time I've ever had it, and by the end of the day, they were taken out, and it was awful. I've had a lot of surgeries, and that one was awful. But anyways, when they do have tonsillitis or recurrent tonsil problems, some of the things they look for, what are you going to be watching for at night to see if they need their tonsils out? Snoring, that's right. My son's tonsils are huge, and I keep trying to get him to take it out because I'm afraid he's going to get that one infection and just close off that airway. But he doesn't snore, so he's still got his tonsils so far. So tonsillectomy is one of the ways they're going to deal with that. So what are some patient and family teaching that you would provide with a tonsillectomy? You can put that on here. Yeah, no red liquids. You want to watch for continuous swallowing. I did start bleeding after my surgery. I blew out the sutures, and it was copious amounts of blood, it felt like. I remember it just pouring out. But anyways, yeah, so you want to watch for frequent swallowing. Why no red liquids? Right. The milk, the ice cream, pudding, why are we avoiding those? Right, and that's probably what I did wrong because I was really excited about the ice cream. So, anyways, they say stay away from popsicle or stay away from ice cream. Stick to popsicles as long as they're not red, and then they can move on to more solid food as they're doing better. You just kind of monitor them. How about pain? When we're giving that pain medicine? Don't wait till it's too late. Don't wait till they're already in severe pain and you have to catch up. You want to start that from the beginning and give it around the clock on that first day, because it is so much easier to stay on top of that pain than to catch up. And a lot of times kids can't tell you, especially younger kids can't tell you that they're in pain. So what would you think are some signs of pain you could monitor for in toddlers? Yeah, just irritable. That's a good good time to talk to the parents. Is this their normal? Are they always fussy? Is this something new? And good parent teaching. Oh, that's a good one. Constipation from pain meds. I like that. Awesome. Yeah, that's a good one. Ah. Mm-hmm.
But it was around the clock every 4 hours, and it was like a good day. And I had to call them and I said, "What do I do?"
Yeah, that's a good point. Definitely, anytime they're on pain medication, especially if they're on the narcotic pain medication. Now you can do ibuprofen and Tylenol. How old do they have to be for ibuprofen? Mm-hmm. And never, ever, ever, ever any aspirin in children, because of the Ray's syndrome that it can cause. I think that's about it on tonsillectomy. Did anybody have any questions on tonsillectomy? Okay. Usually kids recover from this really fast. Like I felt like a big baby because I struggled with it, but it's a lot hard. See, you know too.
Yeah, like my dad had to stay off for 3 days. I'm 20 years old, independent. He had to stay home with me to give me my pain medicine because I couldn't wake up from being knocked out.
Yeah.
And I never wanted to eat. The only time I wanted to eat was overnight. So 3 in the morning, he's in there frying an egg for me.
Yeah, since mine started bleeding again, it took longer till I could eat. So that first bowl of mashed potatoes was amazing. Why would they take out the adenoids?
They're already in there.
Yeah, that's a lot of times. It's just while you're in there, get it out. But also, if they're having frequent rhinorrhea or nasal infections, then that's one reason that they would go ahead and take that out. Are frequent otitis media, so they're getting that mucus backed up from the rhinorrhea into their ears and causing frequent ear infections. You know what? I don't know. Do you know? They shaved hers down? Hmm. Okay. We are on to ear infection. If anybody who has kids, you are very familiar with ear infections. So if you will answer on there, how can you tell if they have acute otitis media? Pulling at the ears, we got that one. Why is their feeding poor? Yep. Yeah, this one, if you've ever had a kid with otitis media, they're extremely irritable, fussy. They're pulling at their ear. Like my son recently had adenovirus, so he was full of mucus, just nasty, blowing his nose. And this was like 4 days into the infection, and he starts running a fever and tells me in the middle of the night, "Mama, my ear hurts." And that's what it was. He had an ear infection. It was just all that mucus that backed up into the ears. Now, when it goes from acute to chronic, where they're getting these ear infections all the time, then they can put tubes in the ears. Did your daughter's tubes fall out? How long afterwards? Has she gotten any infections from since then, or? Okay. Because hopefully they're in there long enough where those structures can grow, and they won't get as many ear infections as they get older. So That's what they're hoping for when it's in there. And since the adenoidectomy helps that, they'll do it at the same time, like hers did a lot of times. They'll take those out together. Some predisposing factors. What are things that make them get them more often? Smoking, yes. Yep, bottle propping. Going to daycares. Frequent sinus infections, yep. So when we have a family member come in and they're complaining about the third ear infection in as many months, and you can smell the cigarette smoke on them, ask them, is anybody smoke in the house? Does anybody smoke around a kid? And they may not be truthful, but just let them know, well, just make sure they don't, because that can increase their likelihood of ear infections. They're smaller and they're getting those upper respiratory infections, use that bulb suction and try to help clear those secretions so that it's not getting backed up. How do we treat otitis media, acute otitis media? Antibiotics, that's right. And we've talked about this a bunch in the slideshow, but what do we want to do when we are giving antibiotics? What kind of teaching? That's right, take them all. Because what that antibiotic is doing is it's going to kill the weakest link first in the bacteria, and if you stop taking it, what's left? The strongest bacteria. And then they're going to be able to mutate and resist those antibiotics in the future. So, and I'm preaching to the choir because I'm awful about never finishing my antibiotics. So, okay, we're going to go on to the croup ones. This one is acute epiglottitis. What is this kid doing over here? That tripod position, right? Unfortunately, I couldn't find any videos of kids because I was interested to see it because I haven't seen this in person. So I was interested to find a video. But they said they're sitting forward, hands holding them up. And why are they sitting like that? That's right. So you're going to want to let them stay in whatever position is comfortable so they can move that air. Drooling because they can't swallow, because that hole's getting smaller and smaller. If you saw on the PowerPoint, we had a before and after, and there's barely anything going through there. They're going to have a muffled voice, depressed respirations. What is the cause of epiglottitis? The Hib, yeah. Now, Hib is vaccinated against, so it's not always the common cause anymore. It's more rare, but it can be caused by viral infection. Like we said, any infection, when it starts here, it's going to spread down. So it's just kind of the luck of the draw if it's going to infect that epiglottitis or that epiglottis. Let's see. Okay. Let's do some nursing interventions for your patient with this. Good. I saw nothing by mouth a few times. That's a good one. Because when you walk in, you're going to want to be able to assess this patient quickly and try to tell what's going on by that drooling, the sitting forward, the position, so that your first impulse is not, let me take your temperature, let me stick a tongue blade in your mouth. Why are we not doing that? Right. We could create a spasm and make that thing close off all the way. Now, that's still a risk, so what are we going to want to have in the room? That's right. You want to be ready. You want to keep the child as calm as possible. Like we said, let them sit in the parent's lap. At Rush, they have a portable Wii. You could roll it now. They did. That was many, many years ago. But you could roll in the room and kind of keep them distracted. Now, depending on how severe this is, they may not be concerned at all with a Wii because they're just trying to breathe, right? But Anyways, like we said, nothing by mouth, and don't look in that throat. You can use cool mist to try to take some of that swelling down, but this is one you're going to want to act fast. So what can we do? What medication can we give them to take that swelling down? Antibiotics, what else? Steroids. It's called racemic epi, and it's inhaled, and they give them that to take that swelling down. Racemic epi, it's epinephrine. So if we can't stick the thermometer, this is an easy one. If you can't stick the thermometer in the mouth, where are we putting it? Mm-hmm. And we do not want to, I saw it somewhere in here, don't lay them supine because that's just going to close it off. So we want to make sure they're sitting up. Mm-hmm. I believe it's RACEMIC. Okay. We're going to move on to croup. Let's hope we can hear this. Yeah. Okay. Oh, wait, she's going to show us his retractions. Okay, what are we hearing? Stridor, that is right. Why are we hearing stridor? Mm-hmm. It's called acute laryngotracheobronchitis. I've been practicing. So any of those structures are going to be swollen and narrowed. Usually they can diagnose this just by listening to them, by signs and symptoms. But if they did an x-ray, they'd see the steeple sign because that's where it's swollen. And actually, they'll also, if they x-ray acute epiglottitis, is going to look like a thumb because it's swollen right through there. But like I said, most of the time they're not going to need to do an x-ray because they can tell just from the signs and symptoms, which are, what are some signs and symptoms? Mm-hmm. That stridor, that barky cough, which is different from acute epiglottitis because they can't cough. They're swollen shut, so there's not going to be coughing in that one. But this one, they still got some opening, so you may hear that. Like I said, it sounds like a seal. Your main treatment goal, maintain the airway. We want to make sure that they can still move air. Okay. She's letting you know that she was with him the whole time and all that good stuff. There's the cough. So now you've heard some of these, so that way when you're in the clinic, the ER, whatever, because a lot of times to me I hear the description that doesn't mean anything until I actually see it and hear it. And you can see on that last video the different retractions. If he were a little smaller, he probably would have been head bobbing because you could see it kind of move as he was working. What are some interventions for croup? The cool mist? Yes. Oral steroids if they can still swallow, which is something we couldn't do in acute epiglottitis, but depending on how severe it is, or that racemic epi like we talked about. Cool mist, they say night is best, so like a ride in the car with the windows down, because this isn't as emergent as the other ones, so they may not be, admitted for this. They're usually given the antibiotics or the steroids and sent home. You want to watch their intake, make sure they're taking enough fluids. Like I said, we had kid at the daycare who had a chronic condition, and we didn't have cool mist at the time, so we used a shower, but that humidified air helps take down some of that swelling. Okay, primary cause of bronchiolitis in children, RSV. Can adults get RSV? Yes. What are symptoms of RSV in adults? Usually in adults, it's not as severe, right? So they're just going to present as a cold a lot of times. But what are some nursing interventions you want to do for children? Because what's happening with children with this bronchiolitis, RSV, is they have the smaller airways. So they get clogged off easier. So they're having the inflammation, they're having that excess mucus production, and whereas adults, we can cough it up, get it moving, they can't because they're smaller. So that's what causes the respiratory distress. It makes it more severe in children. A lot of times, now I don't know if they have loosened that, but a lot of times if it's a newborn, if it's the first few months of life and they get RSV, depending on how they're doing, most of the time they're admitted, at least for observation, because they can turn around really quickly and develop respiratory distress. So you want to make sure to teach the parents signs and symptoms of respiratory distress, which is like we talked about in the beginning, the nasal flaring, the retractions, the changes in their baseline. Are they more irritable than normal, or are they more lethargic? A lot of times these children, as they become more and more distressed, they're working so hard to breathe, as you can see in these videos. So they're compensating, they're working hard, they're getting that oxygen moving, and then they're going to get tired. And so we want to catch it before they get tired, because when they get tired, they're not going to be able to do all that. And that's when their oxygen levels are going to drop. And we're looking at intubation. So you want to keep those oxygen sats above 90%. 100% we want to avoid, because if they're on oxygen, because that means they're probably getting too much. So if you put them on 2 liters and they're sat and steady 100%, doctor's probably going to tell you to take that down a little bit because you're hyperoxygenating them. Oftentimes, 2 liters is a lot for a child unless they're in severe respiratory distress. So you'll see the oxygen meter is going to be broken down. I think it goes as small as maybe like a 32nd of a liter, and then you can titrate around from there. But anyways, what is some prevention for RSV? Synagis, yep. That's given to high-risk patients. They can take Synagis. It's an IM injection once a month during those high-risk months, which are going to be your winter and your spring. How is RSV spread? Or contact with those, wherever those droplets hit. But anyway, so you want to make sure this is extremely contagious. So you want to teach good hand hygiene, cover your mouth when you cough, no sharing of any cups or utensils or anything like that. I know we had a couple years ago at the daycare, the adults got what we thought was a cold. This was before COVID, because we would have been home if it was COVID. We got what we thought was a minor cold, and then we started having a couple kids pop up with RSV. But they don't really swab adults for RSV because it's not as common. So, but yeah, I think that's what was happening. So we were kind of spreading that all around. Now, the biggest problem lifelong with RSV is it can cause scarring on the lungs. So they may have RSV when they're 2, and then as they get older, that may turn into a reactive airway disease or an asthma, where you'll hear that dry cough or wheezing, especially during like the cold and flu season type stuff. But so they want to try to catch this RSV, and keep it as mild as possible so we don't develop those problems. Suctioning, want to keep those secretions out like we talked about, the nose, bronchodilators to open everything up so they can get that mucus up and out. All right. If they have pneumonia, what are you going to hear in the lungs? And cough suppressant in the children, yay, nay? No, that's right. And they will be quick to want to do that because the child's coughing, they look miserable. But instead of cough suppressants, encourage fluids, thin that mucus out. A lot of times they develop pneumonia as a secondary infection because they gave those cough suppressants. And so what started out as an upper respiratory is now pneumonia, and you're hearing the crackles in the lungs and the respiratory distress. And then whooping cough, hopefully you don't see much of this, but it is having a resurgence because that people just aren't vaccinating, and it's extremely contagious. But this was interesting because I haven't heard it either, so hopefully it works.
Howie, you okay, buddy?
They hear that whooping back in as they inhale. That's what's going to tell you it's whooping cough. And it starts out as a mild respiratory infection for the first couple weeks. So you'll see some sneezing, runny nose, and then the cough develops. It's often worse at night. You hear that, like I said, that whooping on inspiration, and it's just they cough so hard. A lot of times they'll vomit. So you want to make sure to watch them closely. You can lie infants on their sides, so that way if they vomit, they don't aspirate because they're already trying to catch their breath, coughing so hard. They can fracture ribs, develop hernias. So you want to watch that airway again, monitor for signs of respiratory distress, encourage fluids, encourage the vaccination beforehand so we don't get to this point. Okay. Yes. Mm-hmm. Yeah. And this is make sure that people aren't kissing your baby on the face. Especially, and RSV as well, because like I said, it can be mild. The adults can be carriers and think they just have a stuffy nose and they're kissing that baby, and then the baby's in respiratory distress with RSV in a week, So definitely. No kissing the babies on the mouth or kissing them on their hands and then they put the hands in their mouth. That always kind of creeped me out though when people they get my baby and they're like, I could eat you up. It's creepy. Anyways, so we will move on to the big ones, asthma and cystic fibrosis. Asthma, what is asthma? Yep. Inflammation, so it's going to cause that wheezing sound, cough, a bronchospasm, chest tightness. Now, when that chest tightness and that wheezing becomes so tight that you don't hear any air moving, that's bad. Yeah. So if there's a silent chest, you're not hearing any air moving, you're going to be intubating. I mean, it's pretty severe. So this video is kind of long, maybe 3.5 minutes, but it's really neat because the doctor is taking care of the child. I believe it's in the ER. So you see the assessment, the treatment, the interview with the parents, and then after the treatment. So hopefully it works.
This young man presents with pretty bad asthma, and he's a known asthmatic, and he's got some breathing treatments at home, but mom's okay with us doing a video here just to kind of demonstrate some of the findings. Respiratory therapist is out there getting all the medications ready for nebulization, but I thought that from a teaching perspective, you can see some intercostal retractions, some subcostal retractions, and if you listen, I'm going to just come up close and you can actually listen. A little nasal congestion, but he's working, and you can almost hear the audible wheezing. Now, he's been wheezing like this how long, Mama?
It just got that bad, and then that's when we brought him straight here from the house, and he started wheezing and breathing like that.
Okay, but he's been coughing for a
Yeah, he was
day.
coughing since this morning, we had gave him some Motrin, and his breathing was light, like, sort of.
Yeah.
Like I could tell he was getting a little sick, that's when I did the albuterol treatment and stuff like that.
Okay, has he ever been intubated, had a tube put in, or?
He did once, when he was like 1, he had the flu.
Yeah.
And the flu was messing with his asthma real bad, and he was in the
PICU?
ICU.
Yeah.
Yeah, and that's when
He got intubated.
tubed up, he was scared.
Okay, all right. Basically, this is your albuterol medication. You have atropine in there too, and then you have a viral filter, and the medicines just basically go straight in. Is this a one-way valve right here? Is that a one-way valve? And what's good about this, it's not wasting any medicine. It's just going straight in. The mask is protecting it. It's not going out into the atmosphere. And then over here, we've got this air exchanger, which is noisy, but it does its job. So that works. Hey, are you feeling better?
You feeling good?
Oh my God.
Are you feeling better?
My goodness.
You feeling good?
Hey, I want to see your tummy. I want to see if your tummy's better.
Oh, you sure enough.
Pull up your shirt. I want to see your muscles. I want to see your six pack. See? Yeah, you're feeling better, aren't you? All right. Thank you, guys.
Anyways, I thought that was neat because you could see him work through the whole thing. Now, one thing, infants especially, they naturally use more muscles to breathe anyways. So abdominal breathing to an extent is normal. So if you see that, that doesn't necessarily mean they're in distress. You're looking at the pulling in around the rib cage, underneath, around the sternum. If they start pulling in up here, they're in some severe distress, like that kid we saw earlier. Also, infants aren't as regular on the respiration, so you may see a slightly irregular respiratory pattern on infants. That's normal as well. Like we said, we're looking for these signs of respiratory distress. There we go. So the PowerPoint, we talked about the signs and symptoms, the coughing, the wheezing, the bronchospasms. A lot of times, asthma, especially the more mild asthma, can be missed because you're looking for that wheezing. They don't always have wheezing. My son was diagnosed with asthma, and his mild, but his main symptom is a dry cough, just a dry, hacky cough that wouldn't go away. It was triggered by a respiratory infection, and so when they did the X-ray, they saw, what do they see on an X-ray for asthma? Hyperinflation, yeah, because they're trapping that air because of the inflammation. So they saw that inflation on the chest X-ray, and so he was diagnosed with asthma. And we got some albuterol treatments. I brought a few things y'all can look at. I kind of stole it from work, so don't tell anybody. But anyways, we have the nebulized breathing treatment. I'm sure y'all seen them in the hospital. And they have a few different. This is like a blow-by. They can put this one in their mouth. They have the mask. Then I have some different inhalers. These are both albuterol inhalers, but I really wanted to see the spacer. Not all of them have the mask. Some of them have like a mouthpiece, but this is the spacer. So you would do like the puffs in here, and then they would inhale, and you'll see this little valve move, and it lets you know that they inhaled like they're supposed to. And that way they're getting all that medication. Because if you've tried to like take an oral temperature on a small child, you see how well that goes to get them to coordinate and follow directions. So this way, they don't have much of a choice. It covers all of that. They're going to get it in. I also have a little bitty nasal cannula just because I think it's neat to see how tiny that is. And then a non-rebreather mask. And then the masks for these are about the same size as well. So, and they have the little nebulizer machines come in different animal shapes. We have a seal at home to kind of get the kids excited. We talked about these children with asthma and their parents need to be really active in their care. So I have an asthma plan. I don't know if it won't let me zoom in. We're zoomed in all the way, but if y'all can zoom in on yours. This is an example. Now some of them, you can look them up. Some of them are more simple, some are more in depth. But it shows if they're in the healthy green, that means they're not coughing or wheezing, they're sleeping good. What about their talking? What are you gonna tell when they get more and more sick? Right, they're not gonna be able to finish those sentences because they're trying to breathe. So that's another symptom, that they can easily measure themselves. Can I talk normally? Am I like this? And I can't finish my sentence because I can't catch my breath. That kind of thing. Then as they get worse, or they start to have a little chest tightness, feel like they can't catch their breath, or they coughing at night and it's waking them up. And then an emergency, that's when they're breathing hard and fast. They have trouble talking. Of course, they start turning blue. Then we're pretty far off there. But anyways, this is a guide that them and their parents can look at. It lets them know what medications to take. So if they're in the green, they're taking their maintenance. What are some maintenance medications? They're Singular. Yeah. And not that you need to see it, but I have a little bottle. Do you know? Yeah. Right. Yeah. That's interesting. I'll have to look that up. I'm not sure. I know that the what's the flu medicine? Tamiflu causes mental changes, nightmares at night and sleep disturbances and stuff like that. So, and going back, how soon do they have to take Tamiflu? 2 days. 2 days. That's right. After 2 days, it's too late. So you really just kind of want to judge to see how sick are they, because Tamiflu is expensive for one. So if it does. So you kind of want to weigh your risks and benefits with that Tamiflu. A lot of people will bypass it, unless of course you have a child like asthma or cystic fibrosis, where you're going to want to get on top of that infection before it causes any problems. So some diagnostic tests we talked about in our PowerPoint was that pulmonary function test, where they're testing the strength of the lungs, and then also they can test their response to treatment, how they're doing. That peak flow meter is something which I really wanted to get, and I didn't get one. But that's something they can use at home, and they know what their goals are, what number they want to use, and they can use that to test. And these action plans will often have the percentage, like if you are 75% of your normal or 60%. If they're below 50%, most of them are say you need to go to the hospital. You need some intervention. What happens if they go to the hospital, they get the bronchodilators, the nebulizer treatments, and they don't improve, they don't respond? What is that called? Status asthmaticus. That's when they are getting their treatments and they're not getting any better. So how do we treat that? You want to give them intubation if they don't respond to humidified O2. You want to give them 3 back-to-back treatments, and then IV corticosteroids like Solumedrol. because, like we said, asthma is that swelling. So they have swelled so much, you got to get that swelling down, and intubation if necessary. Signs and symptoms of an imminent asthma attack. They are sweating profusely. They're sitting up to try to move that air. They change their demeanor, like we said earlier, if they are normally bouncing off the walls and now they're lethargic, or they're becoming irritable, that sense of impending doom. Because if you try to, for example, breathe through a straw, which I didn't have any straws, but I meant to, but breathe through a straw for a little bit, you'll feel more and more anxious as you have trouble catching your breath. You feel yourself get more and more short of oxygen and the buildup of CO2. So that's what they feel. They feel more and more anxious. What are some triggers for asthma? Mm-hmm. Mm-hmm. Exercise, yeah. Mm-hmm. Mm-hmm. Infection. If they're outside and it's cold, just breathing in that cold air can trigger a bronchospasm. What can they do before they exercise? Yeah, do that rescue inhaler or that SABA about 20 to 30 minutes before. It depends what your doctor, some of them say 20, some say 30, to kind of help open everything up before they get out there and start playing. But so education, what are some things we want to educate the family on? Mm-hmm. Mm-hmm. Yeah. Good hygiene, lots of good fluid intake to thin those mucus. I think inhalers. Make sure they know to rinse their mouth out after any of these treatments. What does it cause? Thrush, that's right. So make sure that they know to rinse their mouth out. But if you can, zoom in on this and look over it. This is a good list that tells you about the different medications. Cystic fibrosis. Let me tell you what happens in cystic fibrosis. Yeah, that thick, sticky mucus, because it is an autosomal recessive disorder. What does that mean? From both parents, that's right. Both parents have to have it in order to inherit it. So if mom does and dad doesn't, they're not going to get it. Mom would be known as a carrier. So she just needs to hope she doesn't procreate with someone who is a carrier, because then they have a chance of getting it. But anyways, the mucus that is created in a lot of these glands is thick and it's sticky and it's blocking off. So not only do they have respiratory problems, but anywhere that those glands are that secrete that mucus, they're going to have problems. So sinusitis, because it's up here in the sinuses, GI problems, the pancreas especially. If their pancreas is not working, what chronic disorder can they develop? Diabetes, that's right. And even down to like the sexual organs, so they may not have a period, they may be infertile, or it may delay puberty. So cystic fibrosis, what are some signs and symptoms? Mm-hmm. That meconium ileus, that's found in newborns, that meconium's that first stool, and it's already, if you've seen it, it's already sticky itself, and then you have that thick mucus, and it can create an ileus where they're not able to have a bowel movement, and that's one of the first ways they can diagnose that. How else can we diagnose it? Mm-hmm. The sweat test. If it is greater than 60 milliequivalents per liter chloride, then it's positive, because the glands that are secreting that mucus, they're not able to switch the sodium and chloride in and out of the cells, so they have a buildup of that sodium. So if you were to, I guess, taste their sweat, it'd be extra salty. I'm good, but anyways, what are their stools going to look like? Mm-hmm. Frothy? Why? Mm-hmm. Right. That pancreatic duct is blocked off, so they can't get those enzymes out, the amylase, lipase, and what's that last one? I can't remember. Miss Ruby, amylase, lipase. Yeah, protease. Yay! You get a gold star. Yeah, it is. I could. But anyways, so those break down your proteins and your fats. So instead of being broken down, they're passed out in the stool. So how are you going to know? Well, they have to take the pancreatic enzymes. How do you take those enzymes? Mm-hmm. When do you take them? That's right. You want to make sure you take it with food and snacks. So anytime you eat, you either swallow it whole or you open it up and sprinkle the little insides, on some applesauce, acidic foods. Because if it's not acidic foods, it'll cancel it out. So you don't want to put it in like pudding and stuff like that. Applesauce is a good one. So how do you know those pancreatic enzymes are working? That's right. Look at their stool. So if they're still having the frothy, foul-smelling, oily stool, then that means they're still passing what they're supposed to be breaking down, and they're not on enough pancreatic enzymes, or they're not being compliant. So you want to do a lot of good teaching to make sure that they're compliant. What's going to happen to them if they don't take their pancreatic enzymes? What are they going to look like? Malnourished, failure to thrive. For example, they're not going to be able to absorb those fat-soluble vitamins. Y'all remember what they are? DECA, yeah. So you also want to make sure that they have a good intake of those fat-soluble vitamins, the D, E, K, and A, or DECA. You want to watch their diet, make sure they're taking in good amounts of calories, proteins, and fats to replace what they may not be bringing in. Just like the children with asthma, they're going to have certain things they need to do every day, especially with cystic fibrosis, to keep it under control. You saw a video on the PowerPoint I thought was neat. It was a kid telling you about his daily routine. He took the bronchodilator while he was doing it. A lot of times they'll do that breathing treatment first, and that opens everything up. And then they do the vest, the oscillating vest. I brought one, but it doesn't have the vest. But anyways, what you would do is they have the vest hooked up to here. You turn it on. Let's see if you can hear it. They have different settings that'll tell how frequently to oscillate, or they'll do for so long, like 10 minutes of this, and then they'll do what kind of coughing? Huff coughing, where they'll, and try. And I'm sure you've all done it. If you've had an infection with a lot of mucus and you're trying to get that mucus up, you feel it caught back there. So you're like, I don't want to do it like in this. That's rude. But trying to get it up now. So they'll do so long of this. Like this one's set for 20 minutes. I don't know if you can hear the air. This is where the vest would be if it had been in the bag. And it blows air into there, and it shakes them, and it loosens up those secretions. You can also do chest PT, which is not quite as fancy, but a lot of times it's like a little rubber thing that's round, and it creates a suction. Might see it in the hospital on patients with like pneumonia and stuff. You can also make them. out of any of these little masks with the seal. You cover the hole, and then, can I borrow your back? You're good. And then while they're, after their breathing treatment, you're gonna wanna go around, and they'll tell them different areas they need to do it. You may wanna help drain by posture afterwards. So you see them, maybe lay them on their side, different postures to help that mucus drain, because that's your biggest thing, is getting that mucus out so they can breathe. Okay. All right. And I think, yeah, we'll go ahead and do this one, even though we pretty much just covered it. But if you'll put in some family and patient teaching. Yes, ma'am. Yes. And that's one way they can catch it, is before they leave the hospital. So the meconium ileus, the newborn testing, the sweat test. They can also do the pulmonary function test, just like they do on asthma, to see how those lungs are working. But yeah, they check newborns. And this is interesting, but we had a kid with cystic fibrosis at work, and he was NPO because he had some other issues. So he's getting his feedings with that Mickey button, that G-tube y'all saw. We can't just we can't mix the enzymes with his milk, because then it's not gonna work. So what we do is mix it in a little bit of applesauce, and then water it down a little bit with apple juice, and then put that through the tube. And that's how and then he gets his feeding. That's how he gets his enzymes. I kind of wanted to steal some to bring up here, but anyways. So I thought that was interesting, that's how they give that. Even when he's NPO, they're still mixing it in the applesauce. But all right, what do we got here? We want to watch for signs of infection. With that mucus, they are much more likely to get infection. If they get bacteria in there, it's stuck, and it can continue to grow. And then if they get infected, that's just going to make it worse. Encourage a high water intake. We talked about water thinning those secretions, and watching their stools, humidifying their oxygen. Humidified oxygen is just a good practice for any pediatrics. Elderly also complain about it too, but it dries out those nares, and then you'll get nays like bleeding and stuff like that. And all these respiratory issues, we want to keep these children calm, because the more upset they get, the more oxygen demand they have, and the more distress they get. Pancreatic enzymes is a good one. That high fat, high protein, high calorie diet. Anyways, I think that's about it. Does anybody have any questions on what we reviewed? Uh-huh. Uh-huh.
They put that on for the 20 minutes or whatever,
Mm-hmm.
and then they do the huff cough, or is that huffing cough just something they do to try to heat up?
They're doing that huff cough during their prescribed times. Now they may do it during or after, but that's something they're encouraged to do every day. They want them to do that to try to get that up.
And then after the chest stuff is when they do that.
Yeah, now some of them will do both. That's chest PT or physiotherapy, and then this is the oscillating vest. And sometimes they'll do both. There's also a mucus clearing device that they breathe into and it helps loosen things up. And that's something else. All of these, though, are working towards getting that secretion up. And depending on how bad they are, they may have to do this multiple times a day. And the whole process may last an hour each time. So their life pretty much revolves around getting that mucus out and keeping the airways open and patent. I think that's it right now. If anybody has any other questions. Okay, what's that? We're going to take a break, and then we'll come back in a little bit. So what? Okay. Okay, I know y'all are going to be super excited about this part, but we're going to do group work. So if y'all can get in groups of 4, should work. I think there's going to be like 4 and then one with 5. Group work, group of 4. Okay. The first thing we're going to do is just a little game to kind of help us review. I'm not going to make y'all get in front of the class and do it yet, maybe. So that's why we're going to do it in the group. But this is before all of our time. But have y'all seen the $10,000 pyramid game? That's what we're going to play. So these pyramids, you start at number 1 and work your way through. And it'll have like acute otitis media. So you'll sit back to back. You'll give clues about that without saying the word, like fussiness, irritability. Hello. Okay. Anyway, fussiness, irritability, not wanting to take a bottle, stuff like that. And then your partner has to try to guess what the hints are. And this is just kind of quick thinking, helping you to review. So I'm going to pass these out to your group. So if somebody in your group will put your hand up, y'all can. I'll give you 2. I think that'll work. Oh, I take that back. Let me get one of them. Let me get one of them. Y'all get one. Group. Okay. Group. Woo. Okay, and they have a minute to guess all the things on the pyramid. So y'all just pick. You can either split them up and 2 people give clues and 2 people guess, or however you want to do it. But whoever's guessing can't look at the pyramid. Yeah, like charades. You just can't say the word that's on the pyramid. I have an extra one. Y'all want an extra?
Who wants to go?
Are y'all 2 going?
No, they were thinking about it and they were going to do it to us.
Oh, okay.
See, the thing is, once we do it, we're going to know what they all are.
Yeah, so either.
Okay, well, we can do it.
Okay.
I can do it with her.
And then y'all can switch. No, each one is different. Her paper's different, yeah. So y'all can do each other and then switch. Okay. Each group has different answers, so if y'all want to switch with another group, you can. Yes. The bottom, number 1, because it get harder.
Tammy, this is paper.
And each group's different, so if y'all finish yours and want to trade out, you can. Each one's a little different. That's for later. Okay, real quick, I'm just going to tell you about the next thing, so when y'all finish that, you can move on if you want to. This one is called Put It in Reverse, and you're going to start with an intervention. Some of them are specific, like a certain medication. Some of them are not as specific, and they can apply to multiple illnesses. But you're going to work backwards. What diagnosis would you see that would cause you to do this intervention? What signs and symptoms might they have? What diagnostic tests might you run? What their vital signs may look like? What history might they have? And y'all will just work together in a group, just as long as it's pertinent to this material. Anyways, okay, y'all can go ahead. Okay, so tachycardia, retractions. For this? Yes, You're making your own patient. Yeah.
Cynic epi is the fruit LTB thing. Is it the epiglottitis?
So all you have to do is just pick one.
Is it only those two?
I think it's pretty much those are the only ones we covered. I think there's like two more groups in the book that they talk about, but yeah, those are the two that we talked about.
Yeah, but what about the epiglottitis? Right. We did get it.
Yeah.
She inhaled
Now, of course, if they are so swollen, they're not gonna be able to inhale it any further. You might have more luck with like an IV steroid first, you know what I'm saying? And then when it goes down a little bit, they can get that down. But if they're so swollen that they're not inhaling that, they're probably gonna be intubated at that point.
Is the racemic
Sometimes you don't see that as much. You mainly see it in the croup disorders. Well, the croup's going to be like your LTB and your epiglottitis, and I think there's 2 more that are covered in the book. But basically anything that's causing that infection and swelling in the all those in the upper areas. Come in.
the secretions gonna go back up in the lung, close up the area?
That is, will differentiate between a cool mist and a warm mist. I don't remember, did you say that you had a warm?
No, now if you don't have cool mist, you can use the warm, but now they're getting kind of away from that because they're seeing, like I said, they used to tell you to do a shower.
Right.
And now they're kind of getting away from that, and you're wanting the cool. Yeah, stick their head in the freezer. Yeah.
Okay, that's what our question was. So
Yeah.
really, if we get a question that says warm mist, we need to accommodate.
The only thing I would think about is maybe asthma, because breathing in the cold air could be a trigger.
Right.
But
I know with my asthma kid, they even said the cool.
so that's probably just like maybe not their head in the freezer, but like a cool mist humidifier.
Okay.
You think 5 minutes is enough? 5 more minutes and wrap it up?
Percussion therapy and postural drainage.
Uh-huh.
And they were like, well, you can do percussion therapy in any position. Like sitting up, laying on the side. And the goal
Yeah, right.
of that is just to move the secretions around so they can cough it up.
Right, and so they will put them in different postures to help move it around. Like I saw one video where the mom would it was an infant, so she'd lay him on his side and percuss over here, and then she'd lay him over here. Okay. Okay. Okay, 5 more minutes, and then if you'll pick somebody to present your case study patient you made to the class. Yes, the put it in reverse. Yes, that is yours. And you just make up a patient that you would do this intervention for. Yeah. And there's multiple answers, especially with y'all. So you just pick one that it would work for, whichever one you want to work up. Yeah. Like I said, some of y'all's will have, it can apply to multiple diseases, so just pick one. and work up one patient. That pyramid game seemed to work really well, though. The pyramid game, to get them, it seemed to work really well to get them to reviewing, and I saw they didn't, but the other ones seemed like they got it. But anyways. No, each pyramid is different, and each of these is different. Now they may, like one of them is like administer racemic epi, so it's more specific, or administer a SABA. But then another one may be increase fluid intake. So it could apply to most any of them. But we're making our own case study. We're going to talk about it, and then I got about 15 NCLEX questions to discuss, and then that'll be it. And it's so funny because the little chart they have that they're referring to, I had made for me just like so that I'd have everything in one place to look real quick and I sent it to Miss Martin. I was like, hey, they may want this too. So she printed them out, and they were all like, I love this. I just didn't want to be flipping through pages if they asked me something I couldn't remember. Diagnostics is like what kind of test? What diagnosis does your patient have? Like, is it croup? Is it whatever?
Oh, okay, we're doing.
Yeah, what's the big thing? Yes.
I mean, I'm just guessing.
Yeah.
During an attack or during
Like, what would their vital signs look like? Like, they may have an O2 of 90%. They may have an heart rate of,
elevated, right?
yeah, 180. Their blood pressure is probably going to be up too, because as long as they're, still moving oxygen and they're not going into shock.
Okay.
Respirations are going to be increased. All right. Everything? Y'all good? Okay. Is y'all good? Y'all good? Y'all good? Okay. Y'all good? Okay. All right. We're going to wrap it up and get back to class. So if you want to start first, y'all's group, and tell us about your patient. Hey, listen, you can't hear.
It was intervention was to administer the AV.
Can y'all hear? A little bit? Okay.
From the shoulder diagnostics are really what any listed, but most common cause was the influenza type B. Vital signs was increased respirations and increased heart rate. Relevant history, ages 2 to 5 is the most common, and if they received the Peds vaccine or not. This physical assessment, muffled voice, drooling, tripod position, retractions, poor feeding, and stridor.
All right, they had the administer racemic epi, so they talked about acute epiglottitis. What are some other interventions we could do for that patient they worked up?
More fluids, everybody gets more fluids.
Everybody gets more fluids, yeah.
I think it's the ice kit control, the full mess.
What about if you want to look in their throat?
Nothing in the mouth.
Nothing in the mouth, nothing in the mouth. What are you going to have at the bedside? That's right. Y'all ready? Nothing by mouth.
Our intervention was a pod full compressed neck, so we picked acute infectious laryngitis.
All right.
And our diagnostics were direct swab with culture, fever, vital signs, they would show fever, tachycardia. History would be if they're in daycare, had untreated strep, meningitis, if they were sharing toys, but in their mouth, stuff like that, not complete their antibiotics. And you would see strawberry colored tongue, maybe lethargic, have a rash, swollen lips.
You said you did the strep throat?
Acute untreated strep.
Untreated strep, okay.
Acute infectious laryngitis.
All right. Y'all ready? Okay.
We had administered IV corticosteroid, so we chose status asthmaticus. The diagnostics is a chest X-ray, pulmonary functional test, and a heat flow meter. The vital signs, the respiration would be increased, the O2 would be decreased, and the heart rate would be increased. The regular history is a history of asthma, allergies, and what they were doing prior to the attack. And then the physical assessment would be lung sounds, O2 monitoring, and then doing the heat flow after they've had their medication.
What are some other questions you want to ask the parents when you're treating these asthma kids in the ER? Do you smoke's a good one? Have they been sick recently? And most importantly, what have you taken already? How many times did you use that quick acting inhaler? So that way we know kind of where we're at and how we're responding. You ready?
Okay, we had administered full mist, so we chose RFV. Diagnostics is a nasal swab, and we did a chest X-ray. Vital signs are increased respiration, decreased SAT, increased heart rate, fever. Relevant history would be like an upper respiratory infection. Maybe they go to daycare, contact with somebody that might have been sick. Physical assessment would be cough, poor feeding, nasal flaring, retractions, increased nasal secretions, restlessness because of not able to get enough air, and lethargic, and rhinorrhea.
Yep. So why aren't we giving antibiotics for the RSV? Because it's a virus, yes. And what you're going to see time and time and time and time again are the parents are going to want antibiotics. Because in a bacterial infection, you give antibiotics, the next day they feel better. Viral doesn't work that way. It's got to run its course. Now, of course, if they develop a secondary infection, like what secondary infection could they develop? What else? Ear infection. Then you can get your antibiotics. But the more you give out antibiotics when it's not needed, the more you're creating these super infections. So we need to do good teaching. I have seen families change practitioners multiple times trying to get those antibiotics. But that's not good. So. The tent.
And they were putting in an antiviral through the oxygen that was going into the skin. He had to stay under for 16 hours.
You know, they can give an antiviral that can either, yeah. And that's something we didn't mention also is that tent they can put them in with the cool mist to help with the swelling. You want to go ahead? You ready? Okay.
Our put in reverse was administer antibiotics, so we chose pertussis whooping cough. The physical assessments is sneezing, coughing, fever. They could be tachypnea. They could also have apnea, rib fractures, worsened cough at night. The relevant history, we want to ask, are they vaccinated, unvaccinated, such as specifically DTaP? Did they have a DTaP? Did they have any recent infections? Have they been exposed to someone who possibly has this disease? Vital signs, the O2 will be decreased, there will be a possible fever. Diagnostics, we can look at it to see, examine their cough, are they coughing with it? We can do look at X-ray to make sure they haven't broken any ribs, or fracturing the ribs of coughing. The diagnosis, of course, is the cough. The interventions, besides administering antibiotics, is treat the family prophylactic if no one has been up to date on their vaccine. We can monitor for airway structure for the child. We can make sure they're well hydrated because of a lot of coughing, they can become dehydrated. We can monitor their O2, place them on their side if they're vomiting, we can give antipyretic for the fever. Okay, make sure they're vaccinated.
And anytime your kids have a fever, they're more likely to have other symptoms along with it than an adult would have, like tachypnea and tachycardia. They tend to jump up pretty quickly when they get that fever. And we talked about in the PowerPoint that they're more likely to get a higher fever than we are. So 105 may not be a big deal. Of course, that means it's an infection, but you see 105 in an adult, and we're thinking like sepsis, like something seriously is going on. And then while we're on fever, the seizures, those are not necessarily how high they are, but how fast they move, the febrile seizures. So if they jump up really fast or if they drop really fast. We also talked about in the PowerPoint, just to review, to get it down, make sure to do teaching, don't put them in a cold bathtub, because that's just going to make them shiver, and that's going to raise that fever up more, not to mention putting them in distress. So try to discourage, so you can do the cool compresses on the forehead or under the arms or stuff like that. But anyways, that's just something I was thinking about because that's something you see a lot as well. Y'all can do yours.
We had increased fluid intake and we chose cystic fibrosis. Diagnostic test, chest X-ray or sweat test. Vital signs, 90% O2 sat, or you may see a 90% O2 sat with cyanosis. Blood pressure potentially could be high or elevated, heart rate elevated, and then tachypnea. And then relevant history, usually they're diagnosed when they're younger, especially when they catch it. So they probably already dealt with it for their whole amount of life that they live. And then physical assessment, we did 60 minutes weight loss, foul smelling stools, and the meconium ileus.
All right. What is that fluid doing for cystic fibrosis patients?
Loosening the secretion.
That's right. And I was going to review real quick because there was a question about the chest PT and the posturing. You can do that chest PT in any position. Now they encourage postural drainage, so that's going to be something that's taught by the doctor. What postures to put the child in to help out. Like I saw a video where they had an infant and the mother would turn the baby on its side and do it on the side for a little while. Turn on the other side, put it on its belly. Just different positions. Now, when you're doing the chest PT, when are you going to want to do it according to meal times? You don't want to do it right before because that nasty mucus is probably going to take away their appetite. We really want them to eat, but you don't want to do it right afterwards because then they may vomit because you're beating everything up. So they try to encourage to do it like in the middle of meal time. So if you're eating every 4 hours, maybe 2 hours after and 2 hours before another one. Because remember, it's not just respiratory problems with this. They're also having the GI issues, so.
Our intervention was encourage deep breathing and cough. So the diagnosis we chose pneumonia. Diagnostic test would be like the chest X-ray, a sputum culture, maybe a CDC to check out their white blood count. Vital signs, you can see an decreased O2 sat, the respiratory rate and effort could be increased. A fever, pulse rate could be elevated. Relevant history, someone like smoking around them, if they have a lung scarring from RSV, a history of asthma, a history of previous like pneumonia, they have recurrent pneumonia or whatever, history of cystic fibrosis, any type of lung disorder. The assessment. I don't know what that says. Respiratory effort and rate. Focused respiratory assessment. I check the lung sounds, the use of the accessory method, nasal flaring, rotating. I mean, they have a hard time breathing.
All right. Who else is left? Okay. Yeah. Yeah.
They should have RSV that can be a secondary thing to that.
Yep.
That we put that one. And for physical therapy, this is the lung sound or two sound.
Did y'all go? Yes, you did. Okay. You moved chairs. It confused me. Anyways, so a couple things I wanted to review real quick after that is asthma. One of the triggers that we didn't mention earlier, stress. So you want to assess your patient if there's any stressful environment at home. That could be a trigger, and that's some teaching on the parents. And you want to tread lightly when you teach, make sure they know, but people get really defensive over their parenting. So anyways, a lot of teaching, because like we said, you're not just taking care of the kid, you're taking care of the parents too. On this quick study guide, I listed the medications that are on your syllabus that I was going to quickly go over. I know you can read, but albuterol is that short acting. So when are we going to give that short acting inhaler? What are two different ways you can administer albuterol? A lot of times if the child is has RSV and they're sent home, or they have pneumonia and they're sent home, you're going to get that albuterol breathing treatment. And a lot of times it comes with the mask, and that's what you're going to want to use if you can. They don't always work with that. Not this mask, but this mask. They don't always like the mask and they'll fight it. So you can do blow-by as well, but you're just going to want to try to get as much as you can in there as possible. They can also use that for exercise-induced bronchospasm, so before they exercise. Side effects, they're going to feel real jittery, especially the ones that are going in for asthma and they're getting those back-to-back treatments. They're going to feel nervous, shaky, the heart's going to be tachypnic or tachycardic, they're going to be breathing fast, so you're going to see them. So sometimes that can limit how much we give them. The more shaky and stuff they feel, the more uncomfortable they get. It kind of makes them feel panicky. And then the teaching, make sure if they use that inhaler that they rinse their mouth out, and how to use the spacer to make sure they get everything they can. Prednisone and dexamethasone were systemic corticosteroids. Now, were those long-acting or short, or were they with the rescue or the daily? The rescue, that's right. You don't want to give those every day because steroids can cause increased appetite, acne, stomach upset. Long-term, it can cause stomach ulcers, slow growth, bone disorders. So that's something you don't want to take more than 2 weeks. That's usually just short time. In the hospital, they may get IV Solumedrol, or you may go home on like 3 to 5 days. Yes. So that one you may also want to really watch carefully for in your cystic fibrosis patients because they're already at a risk of diabetes because their pancreas isn't working effectively. The salmeterol is your long-acting. So that's the one they're going to take every day as a maintenance. And it's still the same beta agonist, so you're going to see the same symptoms. Just like we talked about in the last time I was up here when we talked about the nervous system, the sympathetic nervous system, and it's speeding everything up, making everything feel shaky, so that's what they're going through with those side effects. The cromolyn sodium is an anti-allergy medication, so it releases, stops the release of histamine because the allergies can be a trigger for asthma that we talked about. So that's going to kind of decrease that. That's a daily medication. Some side effects are itchy, watery eyes, bad taste in the mouth. And then the Singulair is a leukotriene modifier, and it relaxes the smooth muscles and decreases mucus production. I'm going to look up some of the side effects y'all talked about because that was interesting. But this says it can upset your stomach and cause you to be extra tired. And then make sure they understand this is a daily medication and you're not going to pop one of those pills to stop an acute attack. So, anybody think of any other questions? No? Okay. I'm going to give you, 5-10 minutes? Yeah, let's do 10 more minutes and then we'll come back and do NCLEX and wrap it up. NCLEX questions, review. Surprise, you're taking your NCLEX. Do they just go through and answer all of them and then we discuss? Lumio? I'd rather go. What do y'all want to do? You want to answer all of them and then talk about them or go one at a time? Okay. Yeah. Now it may kick, it kicked us out. Sorry. 636105. Yeah. It froze to death. Hold on. Hold up. Give me 2 seconds. Sorry. Technical difficulties. Okay, did everybody get this one for, no, that's number 3. Sorry. Hmm? Okay. Okay. Sorry. Just go through and answer them, and then we'll discuss them afterwards. I think will be the easiest for the program. In just another minute or so. Looks like everybody's just about done who's doing them. Okay, is everybody finished? Okay. Okay. Question 1, Strider. Looks like most of y'all got that one. Okay, prevention of otitis media. We talked about tobacco smoke. Now, the nasal congestion is the nasal decongestant we want to avoid as much as possible because it can cause rebound congestion. Something else you could do to help, we talked about the suctioning. You can also use saline drops in the nose, and that'll thin out that mucus and get it out. Okay, y'all pretty good with the sweat chloride test. Now they can test for that fecal fat, but that's not going to confirm the diagnosis. Okay. Both are parents are carriers because it's autosomal recessive. Okay, this one kind of split us up a little bit. Why do infants, let's see, quickly have respiratory distress and acute and chronic alterations of the respiratory system? Why is A not the answer? It's not widened. It's a trick question, guys. I'm sorry. They're narrower, more narrow. Yeah. So they are shorter, but they're more narrow. And it's mainly that mucus and edema that's going to obstruct the small airways and narrow, shorter airways. Okay. Teaching for CF, y'all all got that those enzymes need to be given with meals and snacks. Why does it need to be given with the food? Because that's when it needs to work. Yeah, that's right. It's digesting what they're eating. So you want to take it just like that pancreas, when it senses that you're eating, it's going to start releasing those enzymes. It's not able to get it out. It's still releasing them. They're just not going anywhere. So it's causing fibrosis in that pancreas, which leads to the diabetes. But so that's why they need to take it with meals. Okay, the cool humidified oxygen. Why not the erythromycin IV? Because it's a virus, yep. Now, of course, like we said, if they got a secondary infection, then sure. But status asthmaticus, why would we question that order? That's right. Okay. Class of drugs is used to relieve an acute asthma episode. And y'all got the short acting. And those inhaled corticosteroids, those are the ones we talked about in the inhaler that are your long acting. Those are used every day. If you're doing corticosteroids for an acute asthma attack, you want the systemic, which is, how would you take the systemic? IV? PO, yeah, IV. Now they're also going to give you the inhaled, but that's usually used for a long acting. Okay, y'all got that one. They can play anything as long as they're well controlled and they follow their plan. Okay. Yeah, you want to keep the parents with them at all times. When they're in the hospital, the mom can provide constant observation, but their biggest thing, because we're going to be there. Now, if they're at home, you're going to want to make sure to teach those signs of respiratory distress. But we want that mom to stay at the bedside more so to reduce the anxiety. Okay. Apple juice, why not the other ones? The ice cream, because it thickens those secretions. The orange juice is acidic. And the fruit punch is red. Yeah. Okay. Nasal flaring, that's a good one. Why not that respiratory rate of 55 a minute? That's right, that's their normal. And the other two we talked about earlier, that's their normal as well. Okay. And this one is a little split up. Let's see. What was the nurse's first action? If you see a sign that they're in acute epiglottitis, this is saying you are going to get their vital signs and listens to breath sounds, but you're also going to want to make sure you have that tray. Yes.
So I know they in the streets.
Mhm.
We can prepare the intubation be a priority first. We don't have an assessment.
That is the answer.
No. Priority is first, so don't you need to assess before you like.
Well, now you've done the visual assessment, and like we said, acute epiglottitis, you're going to see that when you walk in, they're the way they're looking and everything.
But if somebody, and this is just me, but if somebody comes in and they're short of breath and they coughing, I mean, they may.
They're not coughing. Yeah.
Like, they're in distress, like, in distress. I would need to know vital signs, right? Like,
Yeah.
I'm trying to know, like,
Yeah.
okay, they got something going on versus saying, they're in the back, which You get what I'm saying? You know, like.
Any of the other ones, yes. Now, the reason they're saying that for this one is because you've already assessed them to see that they're drooling, they're doing the tripod sitting, they're doing the croaking sound. Well, if they know that's happening, then we saw them, right?
So, I have a question. So
Yes.
basically, this should have that, the assessment in the question, like, something's going on, get some information.
Yes, and we're not saying we are gonna automatically intubate, but you wanna have it ready because it can go down so quickly.
So wouldn't that be priority though? That's why I'm asking, because it's one of those things, like, if those who the first person put it as a priority, I would think you would get vital signs first, just to address that before you go and get the, because if you call them for vital, they're gonna say, well, what's that vital sign? You don't have nothing. That's why I'm asking.
Mm-hmm.
The only way I could explain this is to say, okay, first of all, when you see a child drooling, is that a good or a bad sign? Is that expected or unexpected? Unexpected. And croaking sound, inspiration, agitation. Okay, when you see somebody that's restless and agitated, you're thinking they're hypoxic, right? That's what you should be thinking. And only sits upright. Okay. If you get the vital signs, you're saying, okay, I'm not really sure you're hypoxic. Let me check your vital signs. And if you call the doctor and they're like, what are their vital signs, you're going to be like, it doesn't matter what their vital signs are because that's what this kid looks like. And they are bad.
Yeah, this is emergent. This is like they could die very quickly.
By getting your vital signs and listening to your breath sounds, you're really kind of delaying getting the problem addressed, which is a very emergent problem that needs to be addressed.
I get that. I guess because it's saying first. Yeah. You know, we have a problem. We got to have first and priority stuff because to me.
Well, you know what? I don't even, if this kid came in, yeah, I would want the vital signs would be nice to know, right? Your breath sounds would be nice to know, but do I really have to know it to know how bad this kid is? Not based on the information that's there. But I understand what you're saying.
Because we had, and this is totally different thing. I'm not arguing, but it was the same situation with an adult, and they were in an emergency situation, and we told them you needed to assess and get vital signs. So I'm trying to see like how can this be different just because it's a child. You know, emergency. I mean, it was an emergency for the adult, and they said, no, you need to get vital signs because you don't have vital, you don't know what's going on. So I guess I'm
speak to that situation to be able to compare it to and help you understand.
It's okay. I just
That this would be equivalent to if your patient came in allergic reaction and they have throat swelling, their throat's closed. Are you gonna do what you can to preserve the airway first, or hold up, let me get your vital signs first? You want to preserve that airway and keep them breathing, then we'll get the rest of the assessment. Clear as mud? Okay, which intervention for treating, this is supposed to say croup, I'm sorry, at home should be taught to the parents? The right answer is take them outside in the evening. Sorry, it's supposed to say croup, so that might have, but croup is an inflammation of the upper airways. Decongestant's going to clear the lower airways and decongest. So the taking them outside is going to decrease that inflammation, and the swelling in the upper airways is your main problem with croup. That's your main priority. We did in a small group, but yeah, stick them in a freezer. Now we did talk about.
That cold air from a freezer, when you open it up, that's gonna help open up their airway. That's why I was talking about going outside at night. I mean, you can't limit yourself and say, oh, we're in the South, it's like muggy outside. The concept is get them in a cool, misty type environment.
Roll the windows down and go for a ride. Now, of course, we talked about in one of the groups, what if they had croup and asthma? Because we know breathing in that cold air can cause an asthma attack. So you may want to use a cool mist humidifier in that situation, and not quite stick them in the freezer. But yeah, you know, like open the freezer and stick their head in. Sorry. Depends on, right? If they are, you can't hear them. So. Any questions? Anything that is muddy? Everybody good and clear? Do you want to add anything, Miss? Okay. We got 6:35. Is that okay? All right. Well, thank y'all very much.